Types of mandibular movements, simplified notes. Mandibular movements are classified in 4 ways. Number 1, based on dimension involved. Mandible can move around 3 axes, sometimes a 4th dimension, time. A. Rotation around transverse hinge axis. Axis runs horizontally from right condyle to left condyle. Movement, pure rotation of mandible around this axis. Occurs during initial opening of mouth, hinge movement. Example, opening mouth without protrusion. Important, during initial opening, axis passes through head of condyle. During later opening, axis shifts and passes through mandibular foramen. B. Rotation around anteroposterior, sagittal axis. Imaginary axis running in the mid-sagittal plane. Movement, slight rotation of mandible around this axis. During lateral movement, one condyle moves, downward plus medially, opposite condyle moves, upward plus laterally, seen in lateral jaw movements. C. Rotation around vertical axis. Axis passes through condyle, posterior border of ramus. Movement, mandible rotates around this vertical axis during lateral movement. Example, moving mandible to the right, vertical axis passes through right condyle. D. Translation in time. 4th dimension, time occurs during Bennett movement. Important, during Bennett movement, mandible does not rotate around an axis. It shifts en masse, as a whole, with time. Number 2, based on type of movement. A. Hinge movement. Definition, pure rotational movement around a horizontal axis. Features, occurs in lower compartment of TMJ, opening approximately 20 to 25 millimeters. Hinge axis, terminal hinge axis. Clinical importance, used during recording of jaw relation. B. Protrusive movement. Mandible moves forward. Movement involves both condyles move forward and downward along articular eminence. C. Retrusive movement. Mandible moves backward. D. Lateral movement. Mandible moves right or left. 2 components. 1. Lateral rotation, laterotrusion. Working side condyle rotates. Lateral translation, Bennett movement. Movement of condyle toward working side. Types, immediate side shift, immediate movement occurs. Progressive side shift, gradual movement during lateral excursion. Number 3, based on extent of movement, border movements. Maximum movements possible. Includes horizontal plane, maximum lateral movements. Sagittal plane, maximum opening and closing movements. Coronal plane, maximum side movements. Envelope of motion, 3-dimensional limit of mandibular movement. Intraborder movements, movements within border limits. Functional movements, chewing cycle, swallowing, yawning, speech. Parafunctional movements, clenching, bruxism, habitual movements. High-yield exam table, movement, axis, main feature, rotation around transverse axis, horizontal axis, hinge opening, rotation around sagittal axis, mid-sagittal axis, lateral movement component, rotation around vertical axis through condyle lateral movement, translation in time, no axis, Bennett movement. Easy memory trick, TSVT axes, transverse hinge opening, sagittal side tilt movement, vertical lateral rotation, time Bennett shift. Prosthodontic importance. Understanding these movements helps in recording jaw relations, selecting articulator settings, arranging denture. Simplified notes. Number 1, lateral movements. Lateral movements occur when the mandible moves to the right or left side. They have 2 components. 1, lateral rotation, laterotrusion. 2, Bennett movement, lateral translation. Tac A, lateral rotation, laterotrusion. Definition, rotation of the mandible away from the mid-sagittal plane. Example, mandible moves to the right side, right condyle becomes the working condyle. Working side versus non-working side. Working side, laterotrusive side, the side towards which the mandible moves. Example, mandible moves right, right condyle, working condyle, mainly rotates. Non-working side, mediotrusive balancing side, the opposite side. Left condyle moves forward, downward, medially. Movements of working condyle. The working condyle can move in different directions. 1. Laterotrusion, moves laterally outward. 2. Laterosirtrusion, moves lateral plus upward. 3. Laterodetrusion, moves laterals downward. 4. Lateroprotrusion, moves lateral forward. 5. Lateroretrusion, moves laterals backward. Non-working condyle movement. During lateral movement, the non-working condyle moves forward, downward, medially. This movement is guided by medial wall of glenoid fossa, entoglenoid process. B. Bennett movement. Definition: Bodily lateral movement, lateral shift of the mandible, resulting from condylar movement along lateral inclines of the mandibular fossa during lateral jaw movements. Simple meaning: the whole mandible shifts sideways during lateral movement. Example: when moving jaw to the right, mandible shifts slightly toward right side. Important points: usually occurs at the non-working condyle. It is a translation movement, measured with respect to time. Therefore, time is considered the fourth dimension of mandibular movement. Types of Bennett movement classification depends on when lateral shift occurs in relation to forward movement of non-working condyle. Number 1, immediate side shift, ISS, definition. Lateral translation occurs before forward movement of the non-working condyle. Features: sudden shift at beginning of movement. Occurs in about 86% of condyles studied. Range: 1 to 4 millimeters, average 0.75 millimeter. Memory: immediate equals shift first, move forward later. Number 2, precurrent side shift. Definition: lateral translation occurs during the first 2-3 millimeters of forward movement of the non-working condyle. Features: majority of shift occurs early. About 75% occurs during first 3 millimeters of forward movement. Memory: precurrent shift begins while forward movement has started. Number 3, progressive side shift, PSS. Definition: lateral translation continues linearly after 2 to 3 millimeter forward movement of the non-working condyle. Features: gradual side shift, continuous during forward movement. Memory: progressive equals gradual continuous shift. Combined movement: some patients show immediate side shift plus progressive side shift sequence. 1, immediate shift occurs first, 2, progressive shift follows. Protrusive movement. Definition: forward movement of mandible occurs during incising food, grasping food. Sequence: 1, condyles rotate initially. 2, after approximately 13 degrees rotation, translation begins. 3, condyles move forward, downward along articular eminence. Complete protrusion: when upper and lower anterior teeth reach edge-to-edge relation, the posterior teeth separate. This posterior separation is called Christensen's phenomenon. Retrusive movement. Definition: backward movement of mandible behind centric relation, produced by temporalis muscle, digastric muscle, deeper fibers of masseter. High-yield exam table: movement, condyle movement, key point, laterotrusion, working condyle rotates, jaw moves to same side. Non-working movement, forward plus downward medial, balancing side. Bennett movement, bodily lateral shift, fourth dimension time, immediate side shift, shift before forward movement, sudden. Precurrent shift, during first 2-3 mm forward movement. Early shift, progressive shift, after 2-3 mm forward movement, continuous shift. Protrusion: condyle translates forward, Christensen phenomenon. Retrusion: mandible moves backward behind centric relation. Prosthodontic importance. These movements are important for setting articulators, recording jaw relations, balanced denture occlusion, understanding cusp movement during lateral excursions. Most asked viva points: 1, Bennett movement equals lateral bodily shift of mandible. 2, time equals fourth dimension of mandibular movement. 3, working condyle equals laterotrusive condyle. 4, non-working condyle equals mediotrusive condyle. 5, Christensen phenomenon equals posterior separation during protrusion. Movements required for normal function: chewing, speech, swallowing, yawning. Parafunctional movements: unnecessary habitual movements, clenching, bruxism, other habitual movements. Important: parafunctional movements occur for a longer duration. Functional movements, about 10 to 15 minutes day. Parafunctional movements, about 4 hours day. Number 2, chewing cycle, Murphy's 6 phases. The chewing cycle has 6 phases. Now 1, preparatory phase. Tongue positions food inside oral cavity. Mandible deviates toward the chewing side. 2, food contact phase, temporary hesitation in movement, caused by sensory receptors detecting food contact. 3, crushing phase, begins with high velocity movement. Speed decreases as food gets crushed. Important: when central incisor is approximately 5 millimeters from closure, jaw motion stabilizes at the working condyle. Final closing stroke is guided by this braced condyle. 4, tooth contact phase. Slight change in movement direction. Reflex muscular adjustments occur for tooth contact. 5, grinding phase. Grinding movement occurs, guided by maxillary occlusal table, mandibular occlusal table. Number 6, centric occlusion phase. Mandible returns to a terminal point, then begins the next preparatory phase. Teardrop tracing. When chewing cycle is recorded in sagittal plane, characteristic pattern, teardrop tracing. Parts, posterior incline PI, food is sliced by cusp inclines. Apex, opposing teeth reach cusp to fossa relationship. Crushing occurs. Anterior incline AI, food dispersion occurs through sluiceways. Number 3, speech. Mandibular movement during speech varies according to syllables, accent, speed. Definitive repeatable jaw tracing during speech is difficult. Number 4, swallowing. Important points. Mandible returns to centric relation position. After swallowing, short pause occurs. Mandible returns to resting position. Tongue function, seals palate, moves bolus posteriorly, helps mandible move posteriorly, superiorly. Number 5, yawning. During yawning, mandible moves forward, downward, up to maximum mouth opening. Movement depends on elastic fibers of TMJ ligaments, condylar movement. Number 6, parafunctional movements include clenching, bruxism, habitual movements. Importance in prosthodontics. Need to consider these movements while fabricating prosthesis because they influence occlusion, denture stability, longevity, border movements. Definition: mandibular movements at the limits dictated by anatomical structures. Features: extreme movements occur in all 3 planes, recorded using a pantograph. Planes of border movement. 1. Horizontal plane produces diamond tracing movement sequence, CR, right lateral, maximum protrusion, left lateral, CR. 2. Sagittal plane produces beak tracing movement sequence, CR, CO, edge-to-edge relation, maximum protrusion, maximum opening, close. Important: during closing, rotation occurs after translation. Condyle returns to centric relation. Number 3. Coronal plane produces shield tracing movement sequence, CO, right canine guided disocclusion, maximum right lateral, maximum opening, maximum left lateral, return to CO. Envelope of motion. Definition: 3-dimensional limiting space within which mandibular movement occurs. First described by Posselt, 1952. Features: longest and widest superiorly, narrows toward maximum mouth opening, MMO. At MMO, space becomes almost zero. Intraborder movements. Movements occurring inside the envelope of motion. 2 types. 1. Functional movements, chewing, swallowing, speech, yawning. Number 2. Parafunctional movements, clenching, bruxism, habitual movements. Customizing occlusal rims, complete denture. Before jaw relation recording, occlusal rims are adjusted for 1. Lip support and labial fullness. 2. Overjet. 3. Cheek support and buccal fullness. 4. Occlusal plane level. 5. Orientation of occlusal plane, lip support and labial fullness. Occlusal rim should provide adequate lip support. Excessive support, lip appears too full. Unnatural appearance. Inadequate support, sunken lips, poor aesthetics. Correction: add remove wax from labial surface. Overjet definition: horizontal overlap of maxillary anterior rim over mandibular rim. Normal: maxillary incisal edge 2 mm ahead of mandibular incisal edge. Modification: increased in class 2 malocclusion, reduced flushed in class 3 malocclusion. Cheek support and buccal fullness. Occlusal rim should remain in the neutral zone. Too much buccal extension, muscle displacement of rim, instability. Too much buccal tooth arrangement, cheek biting. Viva high yield points. Chewing cycle has 6 phases. Chewing tracing equals teardrop tracing. Border movement sagittal plane, beak tracing. Border movement horizontal plane equals diamond tracing. Border movement coronal plane equals shield tracing. Envelope of motion described by Posselt, 1952. Functional movements equals chewing, speech, swallowing, yawning. Parafunctional movements equals clenching, bruxism. Occlusal rim adjustments are done before maxilla. Importance: a complete denture is placed between 2 bones, maxilla, mandible. The denture function depends on the relationship between these 2 bones and the TMJ movements. Types of jaw relations. There are 3 main types. 1. Orientation jaw relation. 2. Vertical jaw relation. 3. Horizontal jaw relation. Number 2. Terms used in jaw relation. A. Orientation relation. Definition: the relation of the mandible when it is kept at its most posterior position and can rotate in the sagittal plane around an imaginary transverse axis passing through or near the condyles. Meaning, it records the relationship of the maxilla to the skull. Importance: determines the angulation of maxilla. transfers maxillary cast to articulator. Necessary before jaw relation recording. Vertical relation, definition, the amount of separation between maxilla and mandible in the frontal plane. Related to vertical dimension of occlusion video, vertical dimension of rest. C. Horizontal relation. Definition, the maxillomandibular relationship in which condyles articulate with the thinnest avascular portion of their discs in the antero-superior position against slopes of articular eminence. Decentric relation. Definition, the most posterior relation of mandible to maxilla at an established vertical dimension. Important, independent of tooth contact, repeatable position. Condyles are in stable position. E. Eccentric jaw relation. Any jaw relation other than centric relation. Examples, protrusive relation, lateral relation. F. Median jaw relation. Any jaw relation when mandible is in the median sagittal plane. G. Posterior border jaw relation. Most posterior relation of mandible to maxilla at a specific vertical relation. H. Protrusive jaw relation. Jaw relation resulting from forward movement of mandible. I. Rest jaw relation. Habitual jaw position when patient is relaxed. Upright position, condyles are in neutral, unstrained position. J. Unstrained jaw relation when muscles have balanced tone, no undue force, no distortion of TMJ tissues. K. Jaw relation record, registration of positional relationship of mandible with respect to maxilla. Can record vertical relations, horizontal relations, orientation relations. 3. Orientation, jaw relation. Facebow definition, GP. A caliper-like device used to record the relationship of maxilla and/or mandible to the temporomandibular joints. Simple meaning, Facebow transfers the relationship of the maxilla to the skull onto an articulator. Functions of Facebow. 1. Records spatial relationship of maxilla to TMJ. 2. Transfers maxillary cast to articulator. 3. Helps reproduce patient's opening axis. Parts of Facebow. 1. U-shaped frame. Main metallic framework. Extends from TMJ region to anterior face. Records cranial plane orientation. Number 2. Condylar rods. 2 rods on both sides. Contact skin over TMJ. Functions. Locate hinge axis. Locate opening axis of TMJ. 3. Bite fork. Inserted into occlusal rim. Records relationship of maxilla to occlusal plane. 4. Locking device. Locks components together. Maintains recorded position. 5. Orbital pointer. Indicates orbital reference point, helps orient Facebow. Number 4. Occlusal rim adjustment. Before jaw relation factors checked. 1. Lip support and labial fullness. 2. Overjet. 3. Cheek support and buccal fullness. 4. Level of occlusal plane. 5. Orientation of occlusal plane. Number 5. Orientation of occlusal plane. The occlusal plane should be parallel to plane of maxilla, determined by anteriorly interpupillary line, posteriorly Camper's line, ala tragus line, ala of nose, tragus of ear. Nahater-Fox plane, used to check occlusal plane. It has inner rim, outer rim. Position, inner rim contacts occlusal rim, outer rim shows facial orientation. Number 6, level of occlusal plane. Maxillary occlusal rim anteriorly, about 2 mm below upper lip during speech. Posteriorly, 2/3 height of retromolar pad. Number 7, overjet adjustment, normal. Maxillary anterior rim is about 2 mm ahead of mandibular rim. Changes Class 2, increase overjet. Class 3, reduce overjet. Edge-to-edge relation may be used. Number 8, lip support and labial fullness. Good lip support, natural facial appearance. Poor lip support, sunken lips, older appearance. Correction, add remove wax from labial surface. Number 9, cheek support and buccal fullness. Occlusal rim should remain in neutral zone. Too much buccal fullness, muscle displacement, denture instability, teeth arranged too buccally, cheek biting. Exam Viva points. Facebow transfers maxillary relationship to articulator. Facebow records orientation jaw relation. CR equals most stable repeatable mandibular position. Vertical relation equals separation between maxilla and mandible. Horizontal relation equals condyle disc relationship. Facebow parts. U-frame, condylar rods, bite fork, locking device, orbital pointer. Occlusal plane. Anterior, interpupillary line. Posterior, ala tragus line. Maxillary occlusal rim, 2 mm below upper lip anteriorly, 2/3 height of retromolar pad posteriorly. These points cover the important exam concepts from pages 121 to 120, pages 124 to 127. Number 1. Types of Facebow. Facebows are classified into A. Arbitrary Facebow. Definition: a face bow that locates the hinge axis approximately rather than recording the true hinge axis. Features: most commonly used in complete denture construction. Condylar rods are positioned approximately 13 millimeters anterior to external auditory meatus. Reference line: canthotragal line, outer canthus of eye, top of tragus. Accuracy: usually locates within 5 millimeters of true hinge axis. Errors may occur in jaw relation, corrected by minor occlusal adjustments. Types of arbitrary face bow. 1. Fascia type reference points. Posterior reference point, 13 millimeters anterior to external auditory meatus. Anterior reference point, orbital, midpoint of lower border of orbit. 2. Earpiece type reference points. Posterior, external auditory meatus. Anterior, orbital features. Earpieces engage external auditory meatus, does not locate true hinge axis. 3. Hanau face bow, spring bow. Most commonly used face bow, used for recording arbitrary hinge axis. Available as arbitrary earpiece type, arbitrary fascia type, kinematic type. 4. Sleomatic type, dinar. Features: has electronic device, gives reading in anterior region. Reading represents half of patient's intercondylar distance. Requires specific articulators that accept this reading. Reference points: posterior external auditory meatus, anterior 43 mm superior to upper central incisor edge in edentulous patients. B. Kinematic hinge bow. Definition: a face bow that records the true hinge axis. Features: used mainly for fixed partial denture, full mouth rehabilitation. Not commonly used in complete dentures because procedure is lengthy, more complex. C. Twirl bow features. Arbitrary face bow. Does not require physical attachment to articulator. Relates maxillary arch to Frankfurt horizontal plane. Easy manipulation. D. Whip mix face bow features. Has built-in hinge axis locator. Automatically locates hinge axis when earpieces are placed in external auditory meatus. Uses: Nacian relator assembly, plastic nosepiece. Number 2. Components of face bow. Bite fork. Definition: a U-shaped plate attached to occlusal rim during orientation jaw relation recording. Features: attached to frame using stem, inserted about 3 millimeters below occlusal surface, sometimes attached with impression compound. Function: transfers maxillary occlusal rim relationship to face bow. Number 2. Locking device functions. Attaches bite fork to U-shaped frame. Supports face bow, occlusal rim, cast during articulation. Components: transfer rod, transverse rod. Auto-adjusting self-centering assembly when transverse rod automatically positions itself after tapping. Number 3. Orbital pointer function marks anterior reference point. Reference: orbital, midpoint of lower border of orbit. Present only in arbitrary face bow. Number 3. Hinge axis. Definition: the imaginary line around which condyles can rotate without translation. Terminal hinge position, most retruded hinge position. Repeatable and recordable, coincides with centric relation. At this position, pure rotation occurs, 12 to 15 degrees, maximum opening, 20 to 25 millimeters. Number 4. Recording orientation jaw relation, using Hanau face bow. Steps. Step 1. Patient position, comfortable, head upright, supported by headrest. Step 2. Mark posterior reference point, 13 millimeters in front of external auditory meatus. A long line from outer canthus, superior border of tragus. Step 3. Mark anterior teeth guidelines on maxillary occlusal rim. Step 4. Prepare notch, about 2 millimeters deep, in first molar region. Purpose: position face bow correctly. Step 5. Insert mandibular occlusal rim. Reduce rim to create space for bite fork. Step 6. Position: U-shaped frame, condylar rods. Move rods to posterior reference points, lock rods. Step 7. Prepare bite fork. Soften aluwax. Shape into horseshoe. Embed bite fork. Combined thickness of wax plus fork should not exceed 6 millimeters. Step 8. Apply petroleum jelly on both occlusal rims. Purpose: easy separation. Viva high yield points arbitrary face bow, approximate hinge axis, kinematic face bow, true hinge axis, Hanau spring bow, most commonly used hinge axis equals imaginary line around which condyles rotate without translation. Terminal hinge position coincides with centric relation, pure rotate 12 to 15 degree. Maximum incisal opening in hinge movement 20 to 25 mm. Bite fork is placed about 3 mm below occlusal surface. Orbital pointer marks orbital a reference point. Face bow transfers maxillary relationship to articulator. Face bow. Hay steps. Step 1. Patient position. Patient seated comfortably, head upright, supported by headrest. Step 2. Mark posterior reference point. A point is marked 13 millimeters anterior to external auditory meatus on a line from outer canthus of eye, superior border of tragus, known as canthotragus line. Step 3. Mark anterior reference. Guidelines for anterior teeth placement are marked on maxillary occlusal rim. Step 4. Prepare occlusal rim. Make a 2 millimeter deep notch in first molar region. Purpose: helps position the facebow correctly. Step 5. Position bite fork. Maxillary and mandibular occlusal rims are placed in mouth. Bite fork with wax is inserted between them. Important: midline of bite fork should coincide with midline of maxillary occlusal rim. Stem of bite fork should be parallel to sagittal plane. Step 6. Attach facebow. U-shaped frame with condylar rods is positioned. Condylar rods are placed on posterior reference points. Rods are locked to the frame. Step 7. Transfer bite fork. Stem of bite fork is locked to transverse rod of facebow. Check position of condylar rods. Step 8. Locate anterior reference point. Infraorbital notch is palpated. Orbital pointer touches infraorbital notch. Pointer is locked using orbital clamp. Step 9. Remove and transfer. Entire facebow assembly plus occlusal rim removed. Transferred to articulator. Number 2. Recording orientation jaw relation using kinematic facebow. Principle: the hinge axis is located by observing mandibular opening movements. Fabrication of clutch. Clutch, a device that relates facebow to mandibular residual ridge. Construction: record base fabricated over mandibular cast. Occlusal rim made from impression compound. Bite fork attached to occlusal rim. Stem extends outside and remains parallel to sagittal plane. Clinical procedure: 1. Clutch placed in patient's mouth. 2. Kinematic facebow attached. 3. Condylar rods positioned approximately 13 millimeters anterior to external auditory meatus on canthotragus line. 4. Patient performs opening movement, closing movement, eccentric movements. 5. Condylar rods are observed. Interpretation: pure rotation of rods, terminal hinge axis, THA, opening with more than 12 to 15 degree, condyle start translation. 6. Rocked. 7. Facebow removed. Number 3. Vertical jaw relation. Definition: the length of the face determined by the amount of separation of jaws. Also, the amount of separation between maxilla and mandible and frontal plane. Hashed importance: correct vertical relation provides proper facial appearance, TMJ comfort, muscle harmony, denture function. Incorrect recording causes increased vertical dimension. Effects: increased lower facial height, trauma to denture bearing area, cheek biting, difficulty in swallowing and speech, TMJ pain clicking, facial muscle stretching, increased oral cavity volume, decreased vertical dimension. Effects: reduced lower facial height, angular cheilitis, loss of lip fullness, wrinkling, muscle tone loss, TMJ discomfort, difficulty swallowing. Factors affecting vertical jaw relation: teeth. In dentulous patients, teeth act as vertical stops. Determine mandibular maxillary relationship. 2. Musculature. Opening and closing muscles maintain tonic balance. Muscle activity determines vertical relation. Vertical jaw relation recorded in 2 positions. 1. Vertical dimension at rest. Vertical dimension at occlusion, VDO, includes the freeway space. Definition: space between upper and lower teeth when mandible is at rest. Formula: VDR equals VDO plus freeway space. Usually freeway space equals 2 to 4 millimeters. Hashbrook: vertical dimension at rest. Definition: the length of the face when the mandible is in rest position. Features: mandible is in physiological rest position. Muscles are in tonic equilibrium. Influenced by muscles of mastication, speech muscles, swallowing muscles, breathing muscles. Important exam points. Facebow records orientation jaw relation. Arbitrary facebow uses approximate hinge axis. Kinematic facebow records true hinge axis. Bite fork midline should coincide with maxillary rim midline. Bite fork stem parallel to sagittal plane. Vertical jaw relation equals separation between maxilla and mandible. VDR, VDO plus freeway space. Freeway space equal 2 4 millimeter. Increased VDO, muscle. Strain, TMJ pain, cheek biting. Decreased VDO, angular cheilitis, loss of lip support. THA equals position where condyle rotates, open quote, the length of the face as determined by the amount of separation of the jaws, GPT, close quote. It is the vertical relationship between maxilla and mandible in the frontal plane. It determines facial height, denture aesthetics, muscle harmony, TMJ comfort. Importance of vertical jaw relation. VJR is the most critical jaw relation record because errors produce early signs of discomfort. Effects of altered vertical dimension. 1. Increased vertical dimension, VDO too high. Clinical effects. Trauma to denture-bearing area. Lower facial height, cheek biting. Difficulty in swallowing and speech, TMJ pain and clicking, stretching of facial muscles, increased oral cavity volume. Mnemonic, high equals hurts. High VDO, muscles stretched, TMJ stress. 2. Decreased vertical dimension, VDO too low. Clinical effects. Lower facial height, angular cheilitis, loss of lip fullness, wrinkling of face, loss of muscle tone, TMJ discomfort, headache neuralgia, corners of mouth turned down, reduced oral cavity volume. Mnemonic. Low, loose face, vertical jaw relation, recorded in 2 positions. Power 1, vertical dimension at rest, VDR. 2, vertical dimension at occlusion, VDO. F, definition, space between upper and lower teeth when mandible is at rest. Exists only during rest. During occlusion, teeth contact, freeway space disappears. Formula, boxed, VDO plus freeway space. Usually, boxed freeway space equivalent to 4 mm. Therefore, VDO should always be 2 to 4 mm less than VR, vertical dimension at rest, VDR. Definition, open quote, the length of the face when the mandible is in rest position, close quote. At rest, muscles are in tonic equilibrium. Condyles are in neutral position. Teeth are not touching. Factors affecting rest position. 1. Gravity and head posture. During recording, patient sits upright, head upright, eyes looking straight ahead, reads baseline should be parallel to floor. Now 2. Muscle condition. Patient should be relaxed. Avoid stress, tension, nervousness because they alter mandibular position. 3. Neuromuscular disease may affect rest position. Methods to record vertical dimension at rest. 1. Facial measurement after swallowing and relaxing. Procedure. Patient sits upright and relaxes. 2 reference points are marked. 1. Tip of nose. 2. Tip of chin. Patient performs lip wetting, swallowing, mandible returns to physiological rest position. Distance between points is measured. 2. Tactile sensation method. Steps. Patient opens mouth wide until discomfort. Slowly closes mouth. Stops when muscles feel relaxed. Distance between reference points is measured. Limitation. Depends on patient's perception. Number 3. Anatomical landmark method. Uses Willis guide. 2 measurements. A. Distance between pupil of eye, corner of mouth, rima oris. B. Distance between anterior nasal spine, lower border of mandible. At rest, AB. Number 4. Speech method. Patient repeats. Sound example, Emma. Mississippi. Distance measured immediately after speech stops. Number 5. Facial expression method. Signs of physiological rest. Eyes relaxed. Skin around eyes, chin relaxed. No excessive wrinkles. Nose breathing normal. Lips slightly touching. No strain. Vertical dimension at occlusion, VDO. Definition, open quote, the length of the face when teeth occlusal rims are in contact and mandible is in centric relation. Close quote. Characteristics. Teeth are touching. Mandible can maintain position for long time. Does not require centric relation always during recording. Methods of recording VDO-A. Mechanical methods. 1. Ridge relation. Defined as, open quote, positional relationship of mandibular ridge to maxillary ridge, close quote. Measured by A. Distance from incisive papilla to mandibular incisors. Important values. Incisive papilla maxillary incisor edge equals 6 mm, overbite equals 2 mm. Therefore, distance to mandibular incisor, 4 mm. B. Parallelism of ridges at occlusion. Mandibular ridge becomes parallel to maxillary ridge. B. Physiological methods include PowerPoint, wax occlusal rims, physiological rest position, phonetics, aesthetics, swallowing threshold, tactile sense, patient comfort. Important exam points. Vertical jaw relation equals separation between maxilla and mandible. VDR, VDO's freeway space equals 2 to 4 mm. VDO is less than VDR. Increased VDO causes TMJ pain, cheek biting, muscle stretching. Decreased VDO causes angular cheilitis and loss of lip support. Rest position depends on muscles plus postures, gravity. Anatomical method, pupil mouth distance, nose chin distance. Speech method commonly uses repeated M sound. Willis guide is used for anatomical measurement. Ridge relation is a mechanical method for VDO recording. It can be recorded by 2 major methods. Number 1, mechanical methods. These methods do not require functional movements. They use mechanical measurements. A. Ridge relation method. Definition, open quote, the positional relationship of the mandibular ridge to the maxillary ridge, close quote. It can be measured by 1. Distance from incisive papilla to mandibular incisors. Important landmarks. Incisive papilla maxillary incisor edge equals 6 millimeters. Normal overbite equals 2 millimeters. Therefore, 6 millimeters, 2 millimeters. So incisive papilla to mandibular incisor, 0.4 millimeters. This measurement helps determine VDO. 2. Ridge parallelism. At occlusion, mandibular ridge should be parallel to maxillary ridge, used to estimate vertical dimension. B. Pre-extraction records used when patient has existing natural teeth before extraction. Types. 1. Profile photographs, taken before extraction. Patient should be in maximum intercuspation, helps reproduce previous VDO. Profile silhouette. Silhouette equals outline of patient's face. Procedure. Patient's facial outline is traced on cardboard. Taken before extraction, used later as a template for restoring VDO. 3. Radiography includes cephalometric profile radiographs, condylar fossa radiographs. Limitation. Accuracy is technique dependent. 4. Articulated casts for dentulous patients. Maxillary cast mounted using facebow transfer. Interocclusal record transfers mandibular cast, used as pre-extraction record. 5. Facial measurements. Before extraction, 2 tattoo reference points placed on upper and lower face. Distance measured at occlusion. Same measurement reproduced after extraction. 6. Measurement from former dentures. Existing denture is a valuable record, measured by Bowley's gauge. Distance between maxillary and mandibular denture borders when in occlusion. Physiological methods. These depend on patient's function and neuromuscular response. A. PowerPoint method, BOOS. Principle. Finds the vertical dimension where maximum biting force occurs. Procedure. Metal plate, central bearing plate, attached to maxillary record base. Bimeter attached to mandibular record base. Patient bites at different jaw separations. Highest pressure reading is PowerPoint. This value determines VDO. B. Using wax occlusal rims. Most commonly used clinical method. Procedure. 1. Determine VDR. 2. Record facial measurements. 3. Estimate VDO, VVDR, died to 5 mm. 4. Insert modified wax rims. 5. Patient swallows and relaxes. 6. Observe freeway space. 7. Adjust until facial appearance is correct, speech is acceptable, comfort is achieved. C. Physiological rest position method. Niswanger and Thompson, 1934. Also called Niswanger method. Procedure. Patient sits upright, head unsupported, eyes looking straight. Patient relaxes, physiological rest position is recorded, freeway space is measured. Limitation. Not very accurate because depends on patient cooperation. Jaw position may vary. D. Phonetics method. Uses speech sounds to determine VDO. 2 important methods. 1. Silverman's closest speaking space. During sounds. S, sh, J. The upper and lower teeth come closest without touching. This minimum space is called Silverman's closest speaking space. Ideal. Lower incisors almost touch palatal surface of upper incisors. 2. FVS sounds used to evaluate anterior tooth relation, vertical dimension. Important exam points. Mechanical methods. Mnemonic, RAF FM. R. Ridge relation. A. Articulated casts. P. Profile photographs. F. Facial measurements. M. Measurement from former dentures. Physiological methods. Mnemonic, PDPS. P. PowerPoint. W. Wax occlusal rims. P. Physiological rest position. S. Speech phonetics. Must remember, incisive papilla, mandibular incisor, 4 mm VDR equals VDO plus freeway space. Freeway space equals 2 to 4 mm. Niswanger method, physiological rest position. Booz methods, maximum biting force. Silverman's closest speaking space equals phonetics method. Profile silhouette equals pre-extraction record for restoring VDO dimension at occlusion VDO, simplified notes. Continuing from previous methods, 3. Phonetic methods. Phonetics uses speech movements of oral tissues to determine the correct vertical dimension. 2 important methods. 1. Silverman's closest speaking space. 2. FV&S, speaking relation. Silverman's closest speaking space. Principle. During pronunciation of certain sounds, ch, s, j, the upper and lower teeth come into their closest position without touching. This minimum space is called Hess-Silverman's closest speaking space. Difference from Niswanger's method, Silverman's method, measures VDO at rest, measures VDO during function, muscles are at physiological rest, muscles are active during speech. Clinical significance. Increased freeway space, VDO is inadequate, too small. Decreased closest speaking space, VDO is excessive, too high. Incisal contact during speech, excessive VDO. B. F, V, and S, speaking anterior tooth relation, Pound and Merle method. Principle. Anterior teeth are arranged according to speech sounds. Different sounds determine different tooth positions. F and V sounds determine position of maxillary anterior teeth, because upper teeth contact the lower lip during these sounds. S sound determines position of mandibular anterior teeth. Procedure. 1. Fabricate maxillary occlusal rim. 2. Adjust rim parallel to Camper's line using Fox plane. 3. Patient pronounces fist, van. 4. Adjust upper rim until upper lip seal is obtained. 5. Mark midline. 6. Place maxillary anterior teeth. 7. Insert mandibular rim with speaking wax. 8. Ask patient to pronounce 60, 65. 9. Adjust mandibular teeth according to speech. 10. Record final VDO. Number 4. Aesthetic method uses facial appearance to determine VDO. Assessment. Skin. Excessive VDO. Face appears stretched. Nasolabial fold disappears. Nasolabial angle increases. Reduced VDO. Face appears collapsed. Wrinkles increase. Lips correct VDO gives proper lip support, normal lip contour. Flattened lips indicate lack of lip support. Do not increase VDO only to improve lip support because it may cause denture failure. Number 5. Swallowing threshold method. Principle. At beginning of swallowing, upper and lower teeth nearly contact. Procedure. 1. Make conical wax rim on mandibular record base. 2. Insert both record bases. 3. Stimulate salivation. 4. Ask patient to swallow. 5. Pressure during swallowing reduces wax height. 6. The reduced height indicates VDO. Number 6. Tactile sense neuromuscular perception method. Principle. Uses patient's perception of comfort. Cash procedure. 1. Insert excessively tall occlusal rims. 2. Gradually remove wax base height. 3. Continue until patient feels comfortable. 4. Comfortable height will VDO. Disadvantage depends on patient cooperation. Number 7. Patient's perception of comfort. A simple method. Insert high occlusal rims. Remove material gradually. Ask patient when bite feels comfortable. The comfortable position indicates acceptable VDO. Horizontal jaw relation. Definition. Relationship of mandible to maxilla in a horizontal plane, also called anteroposterior jaw relation. Types 1. Centric relation. 2. Eccentric relation. Centric relation, CR. Most accepted GPT definition. Open quote. The maxillomandibular relationship where the condyles articulate with the thinnest avascular portion of their discs in the anterior superior position against the slopes of articular eminence, independent of tooth contact. Close quote. Simple explanation. Teeth are not considered. It is a bone-to-bone relationship. Condyles are in a reproducible position. Mandible can rotate around terminal hinge axis. Eccentric relation. Any mandibular position other than centric relation. Examples: protrusive relation, lateral relation. Importance of centric relation. CR is important because repeatable position, independent of teeth, used for complete dentures, helps mount casts on articulator, allows balanced occlusion, useful in edentulous patients. Exam pearls freeway space equals 2 to 4 millimeters. Formula: VDR equals VDO plus freeway space. Silverman space speech method. Booz method, maximum biting force. Niswanger physiological rest position. Pound and Merle, F, V, S sounds, CR, most reproducible jaw position. Eccentric relation, any position other than CR. These are the high yield points from pages 136 to 139. Relation, pages 143 and 146. High yield exam notes. Number 1. Pressureless, static method, nick and notch method. Principle: record-centric relation without applying pressure. Uses indexing, nick plus notch, to relocate the rims accurately. Procedure. Step 1. Prepare mandibular rim. Remove up to 3 millimeters wax from premolar to distal end. This depression is called trough. Remember, mandibular trough. Step 2. Prepare maxillary rim cut. 1 to 2 notches, 1 nick, anterior to notch. Difference between nick and notch. Nick notch, small V-shaped cut. Larger V-shaped cut does not extend across entire rim, extends across entire width. prevents lateral movement, prevents anteroposterior movement. Step 3. Lubricate nick and notch with petroleum jelly. Step 4. Insert rims into patient's mouth. Teach patient to close in, maximum retruded, centric relation, position. Step 5. Train patient by manual guidance, swallowing technique. Manual guidance. Dentist, index fingers, buccal flange, thumb under chin, guide mandible into CR. Swallowing method, patient swallows. During swallowing, mandible naturally reaches centric relation. Step 6, patient repeatedly practices until CR becomes reproducible. Step 7, fill trough with Aluwax, 4.5 mm. Alternative materials, ZNOE impression plaster. Step 8, soften wax. Insert, patient closes in CR. Step 9, Aluwax flows into, nick, notches, creates indexing. Step 10, cool and cold water, trim excess wax. Step 11, articulate casts. Verify CR by intraoral tracing, extraoral tracing. Stapler pin method. Instead of nick and notch, use stapler pins for indexing. Not preferred because CR cannot be verified accurately. Taschner pressure method. Principal pressure is applied while recording CR. Procedure 1. Establish vertical dimension. 2. Maxillary rim inserted. 3. Mandibular rim made slightly taller. 4. Soften mandibular rim. 5. Guide patient into CR. 6. Patient closes until predetermined VDO. 7. Remove. 8. Cool. 9. Mount casts. Haber functional, chew-in, method principle. Uses functional mandibular movements to locate CR. Patient performs. Protrusion, retrusion. Right lateral, left lateral. Requirements: stable record bases, equal pressure, good neuromuscular coordination, tentative CR, tentative VDO. Needleshouse method. Procedure: occlusal rims made of impression compound. Embed 4 metal styli in maxillary rim. Insert rims. Ask patient to perform all mandibular movements. The styli produce diamond-shaped tracing. Interpretation: posteriormost point of diamond equals centric relation. Remember, diamond apex posteriorly equals CR, Patterson's method. Procedure 1. Wax occlusal rims prepared. 2. Trench made in mandibular rim. 3. Fill trench with 1:1 mixture, dental plaster, carborundum. Patient performs mandibular movements. These movements create lateral compensating curve, anteroposterior compensating curve. During movement, material wears away gradually. Continue until desired VDO. Finally, patient retrudes. Fix rims with metal staples. Graphic methods. Uses tracings instead of wax records. Types: 1. Arrow point tracing, Gothic arch tracing. 2. Pantograph. Arrow point tracing records, 1-dimensional tracing, plane, horizontal plane. Pantograph records, 3-dimensional mandibular movements. Factors affecting graphic tracing: 1. Stable denture base. 2. Resistance of occlusal rims. 3. Correct placement of central bearing device. 4. Absence of flabby tissue. 5. Adequate ridge height. 6. Tongue should not interfere. 7. Recording device should function properly. 8. Tracing should end in a sharp apex. Double tracing cause poor neuromuscular coordination. Very high yield MCQs. Q1. Depression created in mandibular rim is called trough. Q2. Material commonly placed in trough? Aluwax. Q3. Nick prevents lateral movement. Q4. Notch prevents anteroposterior movement. Q5. Lubricant used, petroleum jelly. Q6. Functional method using 4 metal styli, Needleshouse method. Q7. Posteriormost point of diamond tracing represents centric relation. Q8. Patterson method uses which mixture? 1:1 dental plaster plus carborundum. Q9. Graphic method records CR by arrow point, Gothic arch, tracing. Q10. Pantograph records, 3-dimensional mandibular movements, 1-minute revision table, method key point. Nick and notch, most common pressureless method, troughs Aluwax. Pressure method, patient closes on softened wax under pressure. Needleshouse, 4 metal styli, diamond tracing, posterior apex equals CR, Patterson, 1:1 carborundum plus plaster and trench. Arrow point tracing, 2D, horizontal plane, graphic method. Using a tracing produced by mandibular movements, also called Gothic arch tracing, arrow point tracing. Principle: a pointer, stylus, is attached to one occlusal rim and a recording plate to the opposite rim. When the patient moves the mandible, protrusive, retrusive, right lateral, left lateral, the pointer draws an arrowhead, Gothic arch. Apex of arrow equals centric relation. Why is it called arrow point? because the tracing resembles an arrowhead Gothic arch. The sharp apex indicates centric relation. Correct versus incorrect tracing. Correct sharp apex, clear lines. Single tracing. Incorrect blunt apex. Double tracing. Irregular tracing means wrong technique, patient movement error, poor neuromuscular coordination. Central bearing device. Definition, GPT. A device that provides a central point of bearing support between maxillary and mandibular arches and records mandibular movements. Components. 1. Central bearing point. Stylus. Metal pointer. Adjustable height. Usually attached to mandibular rim. Can also be attached to maxillary rim. 2. Central bearing plate. Flat metal plate. Usually attached to maxillary rim. Coated with precipitated chalk plus denatured alcohol. Tracing appears on this plate. Function of central bearing device. Record CR. Equalizes occlusal force. Stabilizes denture bases. Helps adjust occlusion. Types of arrow point tracers. There are 2 types. Number 1, intraoral tracer. Location inside mouth. Advantages, simple, small, less bulky. Disadvantages, tracing not visible while recording. Small tracing, difficult to identify apex. Procedure 1, attach stylus and plate. 2, set predetermined VDO. 3, patient performs protrusion lateral movements. 4, observe tracing. 5, sharp apex accept. 6, blunt apex repeat. Number 2, extraoral tracer. Location outside mouth. Advantages, larger tracing, easy visualization, easier apex identification, more accurate. Procedure 1, establish tentative VDO. 2, mount casts. 3, attach stylus and plate. 4, patient performs protrusion, lateral, retrusion. 5, examine tracing. 6, inject, quick setting plaster. Mount casts. Difference, intraoral versus extraoral. Intraoral, extraoral. Inside mouth, outside mouth. Small tracing, large tracing. Difficult to see, easy to see, less accurate, more accurate, simpler, more reliable. Pantographic tracing. Definition GP, a 3-dimensional graphic record of mandibular movements recorded in 3 planes. Records horizontal, sagittal, frontal. Instrument used pantograph. Accuracy. Most accurate method for recording. Centric relation. Eccentric movements. Hash uses full mouth rehabilitation. Programming fully adjustable articulator. Recording eccentric jaw relation. Why not routinely used in complete dentures? Because complete dentures have a real F, resiliency factor, which compensates for minor errors, making pantography unnecessary for routine cases. Pantograph components. Instrument resembles a face bow. Contains 6 flags, 4 around condyles, 2 anterior. Function near condyles. Locate true hinge axis. Anterior flags record antero-posterior movements. Other methods of recording. CR1, even rim contact. 2, celluloid strip, paper strip method. 3, softened wax. 4, conical wax blocks. Celluloid strip method. Place paper strip between rims. Patient closes. Pull strip. Mandible automatically retrudes into centric relation. Conical wax blocks. Wax cones are placed on mandibular rim. Patient bites. Record CR. Eccentric jaw relation. Definition GPT. Any mandibular maxillary relationship other than centric relation. Types. Protrusive relation, right lateral relation, left lateral relation. Y record eccentric jaw relation. To adjust, horizontal condylar inclination, lateral condylar inclination. This helps reproduce eccentric mandibular movements and establish balanced occlusion. Hash factors while recording eccentric relation. 1, condylar path cannot be changed. 2, condyles move in curved S-shaped path, not straight. 3, semi-adjustable articulators cannot reproduce exact eccentric movements. 4, complete denture articulators usually do not support lateral records. 5, fully adjustable articulators reproduce the true condylar path using pantographic tracings. High-yield Viva questions. Q1, apex of Gothic arch tracing indicates centric relation. Q2, shape of tracing, arrowhead Gothic arch. 3, plate is usually attached to maxillary occlusal rim. Q4, stylus usually attached to mandibular occlusal rim. Q5, plate coated with precipitated chalk plus denatured alcohol. Q6, most accurate graphic method. Q7, pantograph records movements in 3 planes 3D. Q8, instrument used pantograph. Q9, main disadvantage of intraoral tracer, apex difficult to identify. Q10, why is extraoral tracer better? Larger tracing and easy visualization. Q11. Celluloid strip method records. Centric relation. Q12. Eccentric relation includes protrusive and lateral relations. One-page rapid revision. Topic, key point, arrow point tracing, Gothic arch tracing, apex equals CR, central bearing device, stylus plus recording plate. Bearing point, usually on mandibular rim. Bearing plate, usually on maxillary rim, coated with chalk. Intraoral tracer, small, not visible, less accurate. Extraoral tracer, large, visible, more accurate. Pantograph, 3D recording, most accurate. Pantograph use, full mouth rehabilitation, fully adjustable articulator. Celluloid strip, pull strip, mandible retrudes to CR. Conical wax block, patient bites on wax cones to record CR. Eccentric jaw relation, any relation other than CR, includes protrusive and lateral movements. Exam tip. From these pages, the most frequently tested topics are arrow point, Gothic arch, tracing, central bearing device, point versus plate, intraoral versus extraoral tracers, pantograph, and eccentric jaw relation. These are the areas to prioritize for Viva and MCQs.